Well, thank you for the introduction, Professor Haddad. I'm going to be talking about groin injuries and the sportsman's groin. So groin injuries, obviously a very common injury in the elite level athlete, especially in sports such as football. And it's around 4 to 19% of all injuries, and even less so in women. The majority are adductor injuries, and these unfortunately can develop into chronic groin pain syndrome if we don't assess them and deal with them appropriately early. We do need a detailed assessment to diagnose the exact problem, and imaging is essential to this. There's many terms that have been used for groin injuries, and here are some of them that have been used in the literature. And this can make it quite confusing when trying to diagnose and treat problems with so many terms. Leading on from that, there was the Doha Agreement in 2015 to try and classify the exact injuries being seen in the groin. And they defined three main categories. And they looked at the clinical entities that we can see on this diagram: adductor-related, iliopsoas-related, inguinal-related, and pubic-related groin pain. They then went on to categorize hip-related groin pain, which I'm going to leave to my other colleagues to explain, and then other causes of groin pain in athletes. Palpation and resistance testing were essential to categorize into these entities. So moving on from that, the assessment is, as always with all musculoskeletal injuries, we need a careful history, we need examination of the exact area and the anatomy, and then potentially imaging with dynamic ultrasound and MRI scan. It's essential to be able to examine for a hernia in the inguinal canal region, as if you find this, then it's a very different problem and we need to involve general surgeons straight away. We can do that with this diagram, placing the finger into the inguinal canal with Valsalva's maneuver. We also need to exclude other causes like hip pathology with examination there, and other areas such as the spine. It's important to be able to distinguish which type of hernia is present, as you can see on this diagram with indirect and direct, and also femoral hernia. The anatomy is very complex and we need to know it to diagnose the problem. As you can see from this clock face in the diagram, it shows how close relation there is from the inguinal ligament to the adductor longus tendon and the rectus abdominis and pubic bone. And that makes diagnosing these problems very difficult, and probably why we've had so many terms like sportsman groin, Gilmore's groin, and athletic pubalgia in the past. So we need to try and go into that and figure out exactly how we define the problems and what type of issues we see in that area. So going into the most common injury we see, it's adductor-related groin pain. The interesting concept that's come up by Schilder's group is the plaque injury. And that is, as you can see from the diagram, the pyramidalis, anterior pubic ligament, and adductor longus complex. You can see that the rectus abdominis does attach to the pubic bone, but the pyramidalis muscle actually traverses the pubic bone and is anterior to that. And this seems to have the connection with the adductor longus. So adductor longus injuries are rarely isolated. They are usually a complex injury, and Schilder's group with MRI scanning has been able to give us a much better understanding of that complex anatomy. They've highlighted a fibrocartilage with specified MRI images. You need a coronal oblique image to give this type of view, and then you can really start to assess the pathology. So Schilder's group went on to classify the plaque injury into 6 different types, depending on what was injured. And this allows us to, as a surgeon especially, deal with the exact ruptures and what needs repairing. The most common type is type 1, and this is where the adductor longus has avulsed. It's very rare that we see rectus abdominis injuries with this, but they can happen in certain types. We also have to assess the pyramidalis and the pectineus muscle. So the type 1 plaque injury, it basically affects the adductor longus and separates it from the pyramidalis,
but the other structures are intact. This MRI scan clearly shows fluid where the adductor longus has ruptured from the pubic bone, and this is a common injury that we see that needs potentially surgical repair in the athlete. So the mechanism of injury, there's been some good work on video footage from footballers, and it's mainly non-contact situations that we see this injury. The presentation is resisted abduction causing pain, bruising around the anterior medial thigh, and usually a boggy swelling. Patients also describe hyperextension injuries due to the pivot point of the pelvis. And how do we treat these? Well, non-operative versus operative, there was a good systematic review in 2020, but it actually highlighted how poor the studies are looking at this area. The largest series only being 7 patients, and we can't really conclude from that data up till 2020 what is the best option. There are newer studies of surgical repair, which are shown in the largest study being from Lampana et al., which showed 40 male athletes having proximal adductor longus tendon repair. The self-reported outcomes were very good, and patients were able to return to sport. But unfortunately, 40% of athletes still had some discomfort during their activities. They put this down to potential plaque injuries being missed and other associated injuries. So it highlights again the importance of imaging and understanding that anatomy to get a good outcome. We have a HCA series under Professor Haddad of professional athletes looking at mainly type 1 plaque injuries in soccer and rugby athletes. We were able to repair the adductor longus with suture anchors and repair the fibrocartilage back to the pyramidalis, which is part of the injury. You can see here from the photos that it's a figure of 4 position, a very small incision, bone anchor placed into the pubic bone, and then sutures applied over the top into the fibrocartilage. There was a good return to sport of 100% at 2-year follow-up, and the return to sport is only 15 weeks. But the main point was to get time from injury to surgery is very short at 17 days, and that is how you get the good outcome. So early referral with this type of injury is important. There's also no recurrence of injury, and there's only minor complications seen, such as wound infection and wound dehiscence. The rehabilitation for this type of repair, well, there's a good case study article seen in the top right here, which goes through the phases and that 14-week program, which is the average to return to sport for the elite level athlete. And the criteria of completion is really determined by pain and range of movement, strength and power. Type 4 plaque injury is a very interesting injury to look at, because 43% of these injuries have rectus abdominis injuries also. The illustrations show how the injury actually detaches the whole pyramidalis and fibrocartilage from the pubic bone. And with it being a severe injury, there can be injuries proceeding proximally up into the inguinal canal. And with that, we might need reinforcement of the inguinal canal to make sure that we don't get any further persisting pain, like Lampana et al. Mentioned. We think that some of these injuries are actually what was described as sports hernia or Gilmore's groin in the past in the literature, and they were just misdiagnosed at the time. We also have a series from Professor Haddad of this type 4 plaque injury with inguinal canal disruption. 7 athletes had to have mesh reinforcement of the posterior inguinal canal due to that weakness from the type of injury. A general surgeon was involved to provide that treatment. Only for transient numbness of the nerve in those patients, which all resolved, and the return to sport was successful in all the patients. Meantime, return to competitive sport was only 13 weeks. Moving on to inguinal-related groin pain, well, we need to know the anatomy again. This MRI scan shows the spermatic cord as the S and pectineus muscle as P. You can see the illustration on the right side, the aponeurosis has been removed, showing the inguinal canal on the spermatic cord exiting and how close it is to the adductor tendon. So this area, we need to know the anatomy in detail. These diagrams show what the canal is made up of, with the anterior wall made of the aponeurosis, the floor made of the inguinal ligament, the roof from other muscles, and then the transversalis fascia making the posterior wall, which seems to be damaged in that type 4 plaque injury. So knowing this anatomy, we can then examine the patient properly and image to decide if this needs repair or not. We also need to know the nerve anatomy. There are 3 nerves traveling in that area, and if they get injured repetitively with scar tissue from this type of problem, then they can get nerve type symptoms as well and may need exploration and a neurolysis during a procedure in the inguinal canal. There was also the Manchester consensus to use the term inguinal disruption as the preferred diagnosis, rather than sportsman hernia or sportsman groin, as there was no true hernia existing in this pathology. 85% of these patients have posterior wall damage in the inguinal canal, needing repair, but we need an MDT approach with tailored physiotherapy initially to see if their symptoms settle, and if not, then surgical repair is potentially there. They use the diagnosis of 3 out of these 5 clinical signs to basically aid you in deciding when surgery may be needed. And they also come up with a table. So in the first 2 months, prehab, rest and analgesia with non-operative measures is the best course of action. And if it goes on longer than 2 to 3 months, then we may need to consider surgical repair with either open or laparoscopic procedures. The main thing is that 40% of athletes with this type of problem had coexisting adductor longus tendon disruption, and that would suggest many of these are plaque type injuries that were just misdiagnosed in the past, as we did not know the exact anatomy. This article is very good at highlighting the different types of problem within the inguinal canal and the nerve adhesions that you may see. And then also going back to Gilmore's groin, which we no longer call this, and we actually call inguinal wall disruption. It was first introduced in the 1980s, and the adductor longus is actually intact in this type of problem. And it seems to be a weakness in the anterior and wall of the inguinal canal, which needs surgical repair usually. So non-operative treatment versus operative treatment for this chronic inguinal wall disruption. Well, there was a systematic review of randomized controlled trials, 345 athletes involved in the analysis, and they found a significant positive effect of physiotherapy, but one RCT compared laparoscopic repair versus non-operative measures and found that laparoscopic repair had a better outcome, with 90% returning to sports, only 7% of athletes in the non-operative group. That's quite a significant difference, and we therefore have to think about operative repair in these chronic groin pain syndrome patients that have inguinal wall disruption. Also going on to pubic-related groin pain, you have to look for local tenderness at the actual pubic symphysis and immediately adjacent to the bone. There's no particular resistance exercise you can do, but you need to exclude an adductor injury or iliopsoas injury with those examinations mentioned. MRI is the investigation of choice, and we can see here 2 patterns that you can diagnose osteotitis pubis. The first pattern being in the younger athlete with bone edema and surrounding edema to the muscles, which usually is self-limiting and just needs non-operative measures. The second pattern is in older athletes, and they can have damage to the pubic symphysis, and the treatment is, again, initial rest and rehabilitation, potential injections, and last resort being debridement and arthrodesis. Other causes of groin pain can be on the lateral side, with tendon ruptures such as the rectus femoris proximal avulsion, And we've just published a review article on quadriceps injuries in the Bone and Joint Journal, which you can look at. The majority being treated non-operatively, but the elite level athlete may need surgical repair. There are other causes of pain, which are too long to go into here, but there is a list, and it depends on careful examination and maybe further investigation. So in conclusion, groin injuries are complex in nature. The anatomy is key to classifying, with the Doha classification helpful. Plaque injuries are a key concept for adductor injuries. We need early diagnosis, and these potentially can become a problem with inguinal disruption, and we need to look at surgical repair in some of these patients. Thank you, and any questions?